Hello, Dr. Ligon.
Yes, sir.
Dr. Ligon. I'm Stan
Nice to meet you,
Richardson.
John Ligon.
I am a community scientist with UF Health Cancer Institute,
Mhm.
and we're going to go ask you a few questions so the community and everybody can tell us about your research and what you do exactly. So, how about just telling us about yourself?
Mhm. Absolutely. So my name is John Ligon. I'm an assistant professor of pediatrics. I do a lot of research about kids with cancer, trying to develop better treatments for them. And when I'm in the hospital, I take care of kids with a wide variety of cancers, including leukemia.
You're currently working on some research right now.
Yes, sir.
Can you tell us about that research? Exactly what it is, what it entails?
Well, a lot of the work that I'm doing at the University of Florida involves clinical trials, trying to
Hmm.
develop new treatments for children with cancer. But additionally, I also work with larger organizations across the country, like the Children's Oncology Group, to better understand, how different subsets of children respond to cancer treatment.
Your research, uh, uh, it is on a particular kind of type of cancer, and you're also studying, I think, relapse. What happens when a patient relapses?
That's right. Yeah. So what we've been looking at with the Children's Oncology Group, which again is a national organization that basically includes all children's hospitals that take care of kids with cancer, um, they have been treating children with acute lymphoblastic leukemia, which is the most common kind of childhood leukemia, for many decades on several different clinical trials. And something that has been known for 15, 20 years now is that one, outcomes are getting better. It used to be back in the 1970s and 1980s that basically a child with leukemia was not going to survive their disease. And now we've gotten to the point where about 90% of children will go on to be long term survivors and grow old and be completely cured of their disease. But something that has been known again for about 10, 15 years is that not all patients are responding at that 90% level. Patients who are Black and patients who are Hispanic have not had as good results as patients who are not Black or not Hispanic. And um, a big area of our research was to try and understand what's the reason behind that. And what we were wondering is part of it that when the cancer comes back, when it relapses, is it because patients who are Black or patients who are Hispanic, are they having worse outcomes after relapse than patients who are not Black or Hispanic?
So, in your research, what did you find? Did you find in a particular socioeconomic background, anything particular stood out that affected these kids with cancer to relapse and their outcomes?
The punchline was that if you control for all of these other factors, race and ethnicity was not as big of a difference maker at relapse compared to the upfront setting. And so one of the conclusions that we made was that um, in order to close this disparity between patients who are white versus patients who are Black and Hispanic, interventions to close that disparity really need to be targeted at the frontline setting. Because once you get to the relapse setting, patients who are relapsed tend to do poorly regardless of whether you're white or Black or Hispanic. So trying to do better for patients up front seems to be an important piece. Another important conclusion that we made, which I think is very timely because in the last 5 years, there have been multiple new drugs that have come onto the market for treating children with relapsed leukemia. Um, and many of those clinical trials have actually shown that patients respond equally well regardless of race or ethnicity. one, we need to try and move these treatments into the frontline setting to help close these gaps. And two, we do know that patients who are, from minority backgrounds tend to be underrepresented in these clinical
Mhm.
trials. And so trying to ensure that patients who are Black, Hispanic, other races and ethnicities have equal access to these new treatment options is also going to be important to close these disparities.
What was your motivation? I mean, what did you when you were a little kid? Did you like say I wanted to be a pediatric oncologist that studied hematology?
No, honestly. So I always knew I wanted to be a pediatrician
Okay.
though. So I remember I would go in. My pediatrician was just one of my favorite people in the world. I would always remember all of the things that he would do to make me laugh every year when I went in to see him on my birthday. I just thought he was the coolest guy, and I wanted to do that. And I grew up and I liked science and all of that stuff. But I always knew that I wanted to be a pediatrician because of my pediatrician being an incredible influence on me. And then it was, I have always been someone who likes, tackling big problems. And I love being involved in research. I love the idea that we don't accept the current standard of care as being all that we can do. That I get up every morning and I try and figure out ways to make things better for patients in the future than they are today.